We're going to move on to our session. So I'd like to invite our moderators first, Chin He from Columbia University and Hwoon Yong Jung from Asan Medical Center to moderate the session. The first session is gastric cancer, why should we care? And it is intended to be a pun, with CARE also being for our Center for Asian Health Research and Education. But I think it is very appropriate. And so this first session will kind of go over the background of gastric cancer and why this is such an important field to address. One other housekeeping note, I think that a lot of you have questions about Wi-Fi. There's a Stanford Public or SHC Public, I forget what it's called, but public, it's just a free access Wi-Fi. You can use that and it's fairly high speed. So with that, I'm going to turn it over to our moderators who will then introduce our speakers. So thank you very much.
Yeah, thanks, Chuha. Dr. Jung and I are, I'm going to speak for Dr. Jung initially. Just pleased to be here and thank you for, we have a nice session on why we should care about gastric cancer. So we've already heard from Dr. Kim and Lauren, but we have a group of talks that are in this vein. So first we'll start with Shailja from the University of UCSD. Dr. Shah is going to speak on the incidence of gastric cancer, both globally and here in the U.S. So.
All right, thank you so much for the introduction and to the organizers for the invitation to speak here today. This is truly certainly my favorite conference and summit of the year, and just being surrounded by friends, colleagues, everybody with that same passion and drive for a common goal. So look forward to yet another wonderful summit. So for the next 15 minutes, I will kick us off with a talk on gastric cancer incidence globally and in the United States. And I've taken the liberty of updating this slightly to also include mortality, which unfortunately, as we see, those go hand in hand in the world as well as in the United States. So here's an outline of what we'll be covering. We'll first start with setting the stage with considerations when interpreting gastric cancer incidence and mortality data. We'll go into gastric cancer incidence and mortality globally with then a spotlight on the United States. And then we'll shift to what I like to call data in action, really discussing some observed trends, projected and future projections, really because better understanding these trends and getting an understanding of potential etiologies really helps inform communities about targeted interventions. So before jumping in, we know that gastric cancer is a very broad term. And so two main categorizations include by anatomic subsite, cardia versus non-cardia, as well as histology. And most of the data that you'll see really combine these unless otherwise specified. So something to really keep note. But cardigastric cancers account for the minority of gastric cancer, about 20%, and there is some geographic as well as population variation there, whereas the majority are non-cardigastric cancers. And what you'll see in some of the data is that that group tends to include as well overlapping as well as not otherwise specified, which, as you know, tends to make up a sizable percentage of those non-cardiac cancers. And so our focus will be on non-cardigastric cancers. And the main histology there, majority is adenocarcinoma, which is our focus. And you can see that there is some variation in terms of the type of adenocarcinoma. And then the remainder are non-adenocarcinomas, so including neuroendocrine tumors as well as GIST, which we'll touch on slightly. So the focus here really is on non-cardia intestinal type adenocarcinoma. And those types of cancers have more of an environmental component to it, with H. pylori being the primary driver along the chorea cascade, which we'll hear plenty about today in the summit. And so other considerations when interpreting the data include understanding that the competing risk of death as well as life expectancy and the impact on some of the global estimates that we see. And so global life expectancy is about 77 years mean across the entire world, but there's significant variation. So several countries in Africa, for example, the mean life expectancy is less than 55 years. And so the lifetime gastric cancer risk and mortality is going to be quite different than other countries such as Japan, South Korea, Hong Kong, Singapore, with mean life expectancy is 85 years or above. Other consideration includes the availability of diagnostic modalities and therapeutics, as well as whether or not countries have programmatic screening. Because especially with programmatic screening, you're picking up asymptomatic cancers, early cancers, which is the goal, but those in other settings where there isn't screening could go undiagnosed. Another consideration includes the data coverage. And so GlobalCan data, which we'll see in the next slide, that has great coverage, 185 countries that provide data, and we can see. But understanding that only about 15% of the world's population is actually covered by high-quality population-based cancer registries. And the remaining data is typically coming from proxy indicators and very sparse data. And last, also understanding that there is a lack of granular data, including in these high-quality population-based cancer registries. And so, like I mentioned, things such as anatomic, subsite, histology, those are very important considerations and have different epidemiologic, risk factor profile considerations. And so those are actually missing even from these high-quality data sources. Certain things that contribute to etiology, including country of origin, H. pylori, also lacking in some of these data sources. And so with that, let's jump in. So based on the most recent GlobalCan data, gastric cancer is the 5th most common cancer and the 4th leading cause of cancer death worldwide, still, 2022 and even now. And so it's responsible for over 1 million cases and over 780,000 related deaths. And as you can see in this heat map, there's wide inter-country variation, and that's very much appreciated here. What's not appreciated is the within-country variation, which is what we'll also touch on today. And the majority of gastric cancer is occurring in Asian countries. And so 75% of all global cases of gastric cancer occur in Asia. 60% of these are in East Asian countries alone. And so highlighting, again, that inter-country variability. And so when we refer to large geographic regions, understanding that there's a lot of variability there. And so understanding incidence is very important because it unfortunately mirrors mortality. And worldwide, the case mortality for gastric cancer is about 75%. And that's higher in certain settings, especially low resource settings, and maybe a little bit lower, certainly in countries that do have programmatic screening, but still there's a high mortality burden. But from a case fatality standpoint, it's lower. Looked at another way, looking at the absolute case burden. And so I mentioned gastric cancer is the 4th leading cause of cancer worldwide. But as you can see here, there are several countries where it ranks 1st, 2nd, 3rd. So 12 countries where gastric cancer is the most common cause of cancer-related death. So several in Latin America, Middle East, as well as Central Asia. 11 where it ranks number 2, 15 countries where it ranks number 3. And understanding the incidence and mortality in certain countries of origin is very important. This is a key point because it is well established that immigrants from areas of high incidence retain that risk when they immigrate to countries of lower incidence. And so this was a systematic review and meta-analysis that we completed a couple of years ago that demonstrated that immigrants from high incidence and high mortality countries, they retain up to 5-fold higher gastric cancer incidence and over 2.5-fold higher gastric cancer mortality. And in this slide, you only see a few countries represented, which is just the nature of the literature and what's been published. But this concept can be extrapolated to all the other high incidence countries and high mortality countries that you saw in those previous heat maps. And it's interesting, I really like this article. So it's a review from 1986, the unplanned triumph of gastric cancer. And so this was before the definitive studies linking H. pylori to gastric cancer, that causal relationship. And so nowhere in this paper does H. pylori actually come up. But you can see, it's amazing to me that the same concepts that we're talking about today were recognized back then. And so you can see that they highlight the importance of understanding immigrant populations and getting that granular data in terms of high versus low risk, immigrant generation, lifestyle factors, cultural factors, dietary factors, age at immigration. So all recognized as important things even back then. And so if we look to the United States is a very diverse country, as you know. And so 30% of the entire population is a first or second generation immigrant, with 80% coming from high incidence, high mortality Latin American and Asian countries, with another about 10% coming from high risk European countries. And you can see a list of those countries here on the right. So 9 of the top 10 countries of origin in the United States are high incidence, high mortality countries. And so this is, and we see this reflected in the gastric cancer risk that we see in the United States. And so with just a lens on California, so we did a population-based study looking at the 10 most populous race and ethnicities in the United States, looking at their gastric cancer risk, including Asian Americans disaggregated by country of origin. And you can see very clearly that there is a disproportionate burden among non-white individuals, so including Hispanic, Black, Asian Americans, including disaggregated by country of origin, and anywhere from 2-fold to up to 13.5-fold higher incidence of gastric cancer compared to the reference group of non-Hispanic white. And what you can also appreciate here, though, is that inter-country variation by country of origin for Asian Americans. So South Asians having a 2-fold higher risk, and Korean Americans 13.5 higher risk of gastric cancer. And so certainly while we do want to move away from race, ethnicity, and country of origin as key risk stratifying agents and move to more precise factors, country of origin is still a very important surrogate marker of risk. And so keeping that in mind as we further our discussion today in the summit. And this is another representation of just understanding the burden of gastric cancer in those high-risk populations. And so to orient you, the beige bars here represent colorectal, colon plus rectum cancer incidence in the United States for those 10 most populous groups. Red is gastric cancer, and blue is esophageal cancer. And you can see across the board, except for non-Hispanic whites, that gastric cancer has a higher incidence compared to esophageal cancer in all groups. And in some groups, including Korean Americans, that gastric cancer incidence actually approaches colorectal cancer incidence. So that's amazing, because what's important to understand here is that the majority of these gastric cancer cases are advanced stage cases. And so this is not even this is probably an underestimate, because we're not picking up those early stage asymptomatic cancers. And so what's unfortunately not represented in the prior slide is our other groups. It's still incomplete data, because we don't have Latin American by country of origin, African American by country of origin, as well as American Indian and Alaska Natives, which we know are high-risk populations in the United States as well. And so this is a wonderful study, and I would encourage everybody to read it. But you can also clearly see that American Indian and Alaska Natives in the United States are a high-risk population, about 2.5-fold higher incidence, as well as mortality compared to white counterparts. And so when we shift over to mortality of gastric cancer in the United States, so even though the United States is a high-resource setting, the case fatality for gastric cancer mirrors the global rates of case fatality for gastric cancer. And that really reflects the advanced stage of diagnoses in the US. And so you can see that only a minority are being diagnosed in a localized stage where curative resection is a possibility. And so slightly lower number of these localized cancers are actually in that early gastric cancer phase prior to submucosal invasion. And this is a nice representation of where we are in the US. And so the red line represents the proportion of early stage gastric cancers in the United States that are diagnosed. So you can see pretty solidly about 24%. And this is in comparison to South Korea, where you can see a nice steady rise in terms of the proportion of early stage gastric cancers that are being diagnosed, to now over 70% of cancers are early stage diagnoses. And that's important because that directly influences survival. So an early stage gastric cancer has a 98% survival at 5 years. So obviously is going to impact mortality. And when we think about gastric cancer mortality in the US, stratified by race and ethnicity, we know that the mortality burden is higher in these high-risk groups just by nature of having higher incidence of the disease. But when we adjust for stage of diagnosis, access to treatment, and other factors, the story gets a little bit more mixed. And so unclear whether or not race and ethnicity independently, when adjusting for those factors, is associated with differences in gastric cancer mortality, but still understanding that that case fatality rate is high. So the universal message is that early diagnosis is the key if we want to impact mortality rates. And so now in the last minute, just wanted to shift over to looking at some observed trends that we're seeing, and really, again, with that motivation, that understanding these trends and patterns really empowers us in terms of how we design our interventions moving forward. And so gastric cancer, I showed that older paper that it was termed an unplanned triumph, and that was because there were sharp declines in gastric cancer incidence as well as mortality without any active intervention, no primary prevention. This was before H. pylori the causal association was recognized, and of course before programmatic screening. And so it was considered an unplanned triumph. But the data that I presented, that still in several countries across the world, gastric cancer is the number 1 or number 2 leading cause of death, that certainly is a different picture than triumphant. And so this was a modeling study that if nothing were to change, that by 2040, we would expect that there would be a 62% rise in the absolute number of gastric cancers to 1.8 million, with a projected 1.3 million deaths. And so these are absolute numbers that still take into account the observed declines as well as an aging population, increasing population. And so reassuringly, we do see a decline in gastric cancer across the world. But the 2 points to make here is that the slope of the decline, the rate of the decline, is not equal across countries. So there's differences there. And also that slope of decline is much lower or shallower than what it used to be a few decades ago, and so might even be plateauing. And so in terms of that heterogeneity, so the global incidence of gastric cancer is down by 28%, with mortality down by 43%. But much of this is driven by declines in high-income Asia-Pacific regions, where you can see the incidence decline is about 50% and mortality decline about 57%. And another trend to keep an eye on is, so while we see that non-cardia gastric cancer as a whole is declining, a lot of that really is driven by declines in adenocarcinoma. And so what we've been seeing, though, is that there is an increase in the incidence of non-adenocarcinoma histologies not related to H. pylori, including malignant neuroendocrine tumors and gastric intestinal stromal tumors. And there are differences there also by race and ethnicity. And so just to conclude, some take-home points. So the burden of gastric cancer remains substantial both worldwide and in the United States, and represents a major public health problem, as we know. And as we'll hear about in talks today, this is preventable. So we see 4th most deadly cancer worldwide and number 1 and number 2 in several countries, which reflects back on U.S. risk as well in those countries and high-risk immigrants. They're promising declines, but have been largely driven by trends in countries with nationwide primary and secondary gastric cancer prevention programs, as well as some passive changes related to improved socioeconomic status, sanitation, and other factors. High-quality data is key to better understanding etiology and modifiable drivers of gastric cancer risk, and certainly developing and implementing targeted interventions for gastric cancer prevention, so really need some high-quality data. And again, attention to trends, because this will provide insight into the changing burden of stomach cancer, which will help plan our gastric cancer interception strategies, monitor their progress, as well as make iterative changes. Thank you so much.